Good morning again. Sorry for the interruption. These are few technical issues out of my control. So anyhow, it's good. So what you can do is you can take that first half of the first 40 minutes as the part one and have a rest and again go through the second half of this lecture. Okay. So we'll start from sodium. That is the reason why I don't prefer the Zoom lectures, because a few the technical errors, even though I'm having a good Wi-Fi connection, proper laptop, proper headset, everything, still there are issues. That's the reason I don't prefer the Zoom. But considering the prevailing situation in our faculty, we have to go with. So don't worry if they are the breakage of my voices. Just ignore that. The PowerPoint notes are very easy to understand, very clear. Step-by-step approach is fine. And I'll be giving an additional supplementary or complementary notes, which is 6 pages or something. That's contain the indication, mechanism of action, the doses, side effects, and contraindication. Those are there. Go through. No need to worry about that. Everything hopefully in the very concise manner. The gist you will get it. Always check that with the BMS. Okay, we'll move here. Sodium glucose co-transport inhibitors. So they inhibit reabsorption at the proximal converter tubule. So increase glycosuria, reduce the blood glucose load, and empagliflozin, dapagliflozin, canagliflozin. There is no risk of hypoglycemia, moderate weight loss, as they are reduce the water and the glucose. With that, the sodium also pass, so reduce the blood pressure. So main side effect, it will cause orthostatic hypotension, urogenital infection, including genital candidiasis, because the sugary urine is passing. A moderate increase in LDL level, especially for canagliflozin, and there are fungal infection, and there's a euglycemic ketoacidosis, corneous gangrene, also one of the side effects. So in addition to the blood glucose lowering, it lower the body weight, improve renal dysfunction, and reduce the risk of atherosclerotic cardiovascular events and heart failure. So how they reduce cardiovascular mortality? Increase natriuresis leading to fluid loss and a small reduction in systolic blood pressure. There's an increased production of the ketones acting as a superfuel for the heart. The vasodilation through blockade of renin-angiotensin system and direct effect on the heart also helps them. So this is another wonderful graph. If you see the sodium glucose for transporter, we are blocking here. So the glucose is sent or excreted via the urine. So increase urinary sodium and glucose because it affects both sodium glucose for transporter. So there's an increased glucagon to insulin ratio, that is lipolysis, weight loss, reduced plasma volume, and improved endothelial functions. Again, reduce the blood pressure and afterload. Because of the diuresis, sodium and glucose and water goes out. Ventricular preload is reduces, so that improve your ventricular loading condition and weight loss. And because of this hypoxemia, hypoxic effect, you will get increased hematocrit also. Another drug is alpha glucosidase inhibitor. This acts on the GI tract. So it is an acarbose, miglitol. It's in the small intestine. Usually alpha glucosidase is converts polysaccharides to monosaccharides. Then it makes the absorption easier. But alpha glucosidase inhibitase block the alpha glucosidase, so absorption of the monosaccharides are reduced. It delays glucose absorption and reduces postprandial glucose rise. It's beneficial in both type 1 and type 2 diabetes, the monotherapy, or you can use as a combination. It usually taken with the first bite of the food. Flatulence, abdominal discomfort, and diarrhea are side effects. Rarely, hepatic damage is possible. Another group of drug is meglitinides. It's a quick, short-acting stimulation of insulin release in response to the meal. It also acts like sulfonylurea. They act by blockade of ATP-dependent potassium channel. It usually taken with a meal. If there's no meal, no tablet. That's the policy. It reduces postprandial hyperglycemia. Side effects are hypoglycemia, headache, and arthralgia. Another thing is incretins. The incretins are we have seen during DPP4 inhibitors, GLP, glucagon-like peptide, GIP, glucose-dependent insulinotropic polypeptide. What is incretin effect? When you have a meal, your body's response to that meal will increase insulin secretion in the body. That is incretin effect. So they will say in this term, oral glucose elicits higher insulin secretory responses than IV glucose, despite inducing similar levels of glycemia in healthy individuals. But know what is incretin effect? That's what I said earlier. So the incretins stimulates insulin, lower blood sugar. The DPP4 enzyme inactivate incretins. So we block this via giving blockers. Instead of blocking that, what we can do is we can give incretin analog like GLP-1, GIP analog we can give. So we don't need to worry about much this pathway, this blockade. We have more GLP and GIP analog. So they increase insulin secretion and reduce your blood sugar level. A functional analog of incretin, so they enhance insulin secretion in response to rise in blood sugar, reduce glucagon secretion, slow gastric emptying, act on brain GLP receptors to reduce appetite. The names are exenatide, liraglutide, lixisenide, like that there are few names. They are usually given subcutaneously once or twice daily. They are long-acting analog, but semaglutide is the only oral preparation is available. Remember this following point. Unlike DPP4 inhibitors that restore physiological creatine level, GLP-1 receptor agonists achieve pharmacological levels and therefore they are more potent than DPP4 inhibitors. It causes nausea, vomiting, bloating, and diarrhea as a side effect, mainly GI side effect. If you are having a history of pancreatitis, you should not give. So there are few other therapies. The release of the bromocriptine, the research says it's a dopamine agonist. It has a wonderful effect on reduction of your blood sugar. We don't know the exact mechanism, but it has something to do with the dopamine circadian rhythm. So cholesyvalum is a bile acid binding resin It also reduces the blood glucose level. So these names can be asked as MCQ. So the following drugs are reduced blood sugar level. So they will ask bromocriptine, that's true. Cholesterol, that's also true. So know these rare or other classes of drugs. So interaction with non-diabetic drugs, we just go through this. This may be asked at the like the thiazide diuretics at higher doses than those now generally used in hypertension can precipitate or worsen diabetes. Okay, like that, the few points you have to know. Just go through this, and the key factors when considering appropriate therapy in diabetes. You have to know the risk of hypoglycemia, effects on body weight, side effects, cost, patient preferences. So usually we start with metformin, then we'll combine with sulfonylurea and other drugs, then we'll go. And at one point, we change this into insulin therapy. So when you are going to change insulin, because when there's ongoing catabolism, the severe weight loss, symptoms of hyperglycemia is still present, we will change into insulin. That's a different lecture, so just an idea to give you. At one point, if the drugs are not working, we are going to change to insulin. So have a chart like that will be useful for your preferences. And this is a summary. This just a wonderful summary. You just go through. I have given you the main major action of the drug. Like metformin increase glucose uptake, meglitidine and sulfonylurea increase insulin release, DPP for insulin secretion, SGLT2 inhibitors increase renal glucose excretion, like that. And this is the chart what I have mentioned you. I have made it for you all. Class of drug, mechanism, site of action, main advantage and the main side effect. You prepare yourself or you just go through, remember few points we'll be asking. That's it. And there's other thing called HbA1c. You may remember, you may heard of that. Because these are now become a kind of gold standard for diagnosis of diabetes. If HbA1c level is below than 5.6, it is normal. 5.7 to 6.4, that is pre-diabetic. More than 6.5 is diabetic. But at this pre-diabetes level, via proper exercise, proper calorie intake, having a proper sleep, you can bring that back to normal. Even without the drug, that's the possibility. So these are the percentage and the millimole and other, just for your references, just go through. It's very, the normal range 5 to 7. So that is fasting less than 117. Okay. Millimole 6.5. So they have said something like that. So you have any questions? Hope you all are brilliant students. You don't find it difficult. So if you have any problem, you can contact me via WhatsApp or my email. I always say, may peace be upon you all. And thank you very much. And I again tell you, if there's any problem in the uh, if there's any problem, what you can do is you just go through my slides. It will give you a proper idea. You don't need to worry about whether you don't need to worry about if there's a discontinuity of the video or my voice, because I have given you the PowerPoint presentation. It's almost from the pharmacology books, medicine books, and clinical medicine books, and with from other research articles. So it's a kind of comprehensive. On addition to that, I'll be giving a supplementary notes also. So everything will be given you via the LMS or via your physiology repa. Okay. Have a nice day. Thank you very much.